So how do we treat? Well, what's the sequence of treating patients with epilepsy? Well, once you diagnose them, you try on one AED. Again, you want to maximize that dose. That's really crucial. So if you tried levetiracetam and the patient's only gone up to 500 milligrams twice a day, that doesn't mean, and they're still having seizures, that doesn't mean they failed it. It's very important to keep going up and up, and as long as the patient can tolerate the side effects, you want to maximize that. And basically 4,000 milligrams is sort of the maximum that I'm familiar with. Sometimes you need to get close to toxic levels. On Dilantin, for example, you want, as you know, the range for Dilantin is 10 to 20. Well, sometimes you'll have to get them up to 23, 24, even 25. And if they're tolerating it, that might be where you need to go. So you want to maximize that. But if that doesn't work, you try a second one. At that point, you can try a third, or you can try duotherapy, or you refer them to the EMU. For possible surgery. The official definition, which is not, no one likes this definition, but more than 30 minutes of continuous seizure activity, or 2 or more sequential seizures without return to consciousness. So those are the official definitions. But really, in practice, anyone who has a seizure for more than 5 minutes should be considered to be in status. If someone, as I'm sure you all know, and when I evaluate a patient on the floor who's having a seizure, if they're having a seizure, you don't treat them if they've had one for just a 1 minute seizure. There's nothing, you don't need to do anything. It's after 3, 4, and then 5 minutes. They're still seizing. That's when we want to get out the Ativan. So it's anything lasting more than 5 minutes is something that needs to be treated. Part of the problem is that we end up sometimes patients go a lot longer than that before they're actually treated, especially when they're in non-convulsive status. Convulsive is easy to diagnose, anyone can do it. Non-convulsive, you may have absolutely no clue that they're convulsing. Usually those patients are in complex partial status. That would be the most common situation. And they may be doing absolutely nothing, lying there in a coma, or they may be acting kind of weird. They might have something, a very subtle motor type of symptom. Very, very difficult to diagnose, as you all know. Really, non-convulsive, not often, but it pretty much always requires an EEG for diagnosis. You can have a high clinical index of suspicion based on some criteria. If the patient has a history of seizures, they're going to be at higher risk for being a non-convulsive. If they're having very subtle motor function, motor signs, that's pretty subtle. Actually, that's a pretty good indication that might be non-convulsive. If they're having kind of fluctuating periods of relative reactivity to you, and other periods where they're not reacting to you at all, that can be a sign that they might be in non-convulsive, that they might be having repeated seizures. Almost 1 in 10 patients who just coma. They just went around did EEGs on patients who were in coma in the MICU without any seizure activity whatsoever, and they were actually in status. So that's why we end up doing so many rule-outs. Over half do not even have a history of epilepsy. But yet, if they have epilepsy, they have a high chance of experiencing status at some point. So what do we do? How do we diagnose someone? Well, first thing we do is we try to treat before we really do anything. Sometimes, as you know, sometimes before we even draw labs or before we get that emergent EEG, we'll treat them with a little bit of Ativan just to see what happens. But you want to draw your standard labs. Sometimes, again, they'll require lumbar puncture when you suspect a CNS infection. And you only get the neuroimaging after you treat it. As I mentioned before, you want to get a CAT scan to evaluate for an acute cause. Sometimes the patient, we already know they have epilepsy, so there's no real reason to get a CAT scan. There's no reason to get an MRI. We already know they have it. We're just going to treat them. Indications for continuous EEG monitoring. I know that's a lot of information. I apologize. Way too much text on here. But basically, anyone who has had a seizure, we know they've had a seizure, especially if they've had a flurry of seizures and they're not waking up. They've just bought themselves 24-hour continuous EEG monitoring. We get a lot of patients who are transferred here from another hospital who are thought to be in non-convulsive status. They may get here and we may look at them and say, this patient's not in non-convulsive status. But we still order the EEG anyway because you're really supposed to, you know, for whatever reason. Patients are having basically any kind of clinical activity that's suspicious for a seizure, they'll get continuous EEG monitoring. A lot of patients in the neurological ICU or even in the NICU who have altered consciousness without any clear explanation, they'll get continuous EEG. Any kind of spell that's in comatose patients that could represent a seizure will get an EEG, continuous EEG too. A seizure alone on EEG does not equal status. Again, they need to have a certain period of time. They need to have multiple seizures and not return to baseline. Those would be status on EEG. So, just a couple of EEGs here. This is the generalized spike and wave. Any number that's odd is going to be on the left side. Any number that's even is going to be on the right side, left, right. F means frontal, C means central, P means parietal, O means occipital. And you can see this is, would you call this a generalized or a partial seizure? Of course, generalized seizure, yeah, because it's you're finding it in all parts, both left and right, and in all parts of the brain. So this would be a generalized seizure. You guys have all heard of PLEDs, periodic lateralized epileptiform discharges, classically seen in patients with herpes, but also an acute stroke or trauma. You can see PLEDs, and here's what it looks like, right here. PLEDs is an easy one to remember because it stands for periodic, meaning it comes in a periodic, same interval time. Boom, boom. It's usually going to be lateralized to one side. So here it's on the right side. Remember, even numbers are on the right. And they're epileptiform discharges. These are of course epileptiform discharges. They are spiky, and then there's aftergoing slow wave. Those would be sharp spike and wave. So this is what we would call PLEDs. PLEDs are not considered to be actual seizures. Okay, they're considered to put you at higher risk for having seizures within the next 24 hours. But this is actually not considered to be status. How do we treat status? Well, have a plan. As you know, we already have a plan here at University Hospital. We have a protocol to treat it. But you want to follow the ABCs. You want to treat with IV medications. Most often, sometimes you don't have that option. You can treat intramuscular or rectally if you have to. But obviously, you need to stop it. That's the end point. It is considered to be a neurologic emergency. Don't hesitate to, especially with our rotators, you don't know if you suspect patients in status. This is an emergency, and their death rate, their mortality rate rises dramatically after 1 hour. So this needs to be attended to immediately. Okay, so therapy, ensure airway and oxygenation, obtain baseline blood studies, get IV access. We're supposed to give IV thiamine and glucose in practice. Oftentimes the residents don't do that. But the AEDs is really the crucial component, okay? And you need to get those studies. By diagnostic studies, it's usually going to be the serum studies as well as oftentimes you need a head CT. Those are the first things you want to do. The medication of choice in someone who you suspect status is Ativan. We give them in 2 milligram increments. And you can give every couple minutes up to a maximum dose of 0.1 mg per kg. Usually after 6 milligrams, if they haven't responded, they probably won't. So you move quickly onto the next medication if Ativan doesn't work. Luckily, the majority of patients in status will respond to Ativan. Thank goodness for that, because it gets harder and harder to treat them if they fail Ativan. And the sooner that they're treated, the more likely they are to be successfully treated. So only if they failed Ativan. I mean, if they've stopped seizing, you don't need to continue down the status protocol. But if they are still seizing, the next drug after Ativan is fosphenytoin, or in our case now it's phenytoin. But once we get the supply of fosphenytoin back, we go back to this. It's a great drug. 20 phenytoin equivalent, or just 20 mg per kg is the number that I remember. You can run it in as fast as 150 mg per minute, but honestly, I I don't like that rate. I think it's kind of fast, as you guys may know, as you probably know. It can cause blood pressure problems, hypotension, bradyarrhythmias.